solitary thyroid nodule. Solitary thyroid nodule is a clinical term denoting the presence of a single palpable nodule in the thyroid gland. No other part of the thyroid gland is palpable. What does that mean? That means some patient present to you with a thyroid swelling, and when you examine the patient, you find there is a single nodule in the thyroid by palpation. This nodule could be truly it is a single nodule, or could be it is part of a simple nodular goiter, or there are other non-palpable nodule in the thyroid gland. And many solitary thyroid nodule on a clinical examination may turn to a multinodular goiter at operation. Why solitary thyroid nodule is important to be assessed? Because there is high incidence of malignancy when compared to multinodular goiter. Single solitary thyroid nodule, it is the most common surgical disease of the thyroid gland. It forms about 4% in general population. 4% of general population have solitary thyroid nodule. Sex ratio 4 times more common in women. About 15 to 30% of patients of solitary thyroid nodule have nodule on other side of the gland. Solitary thyroid nodule in male has a risk of malignancy about 48%, while in female it is about 12%. This is solid. Look to this percent. We called it rule of 12. 12 in female, 4 times this 12 in male. This is for the risk of malignancy. While in solitary cystic, the risk in males is 24, double the 12. While in the female, it's about 6%, half this 12. In general, the incidence of malignancy is about 8 to 10%. So you can imagine how it is high risk of malignancy in this problem. Aim of assessment is to identify a solitary nodule which has high risk of malignancy. The main risk now is male sex, solid nodule, and solitary nodule. Now you can compare that in solitary thyroid nodule, the general risk of malignancy is about 8 to 10%. Compare it with simple multinodular goiter, which is about 1 to 2% risk of malignancy. Findings that raise suspicion of malignancy in a solitary nodule are history of a previous irradiation, male patients with solid nodule, young and elderly patients, recent onset and rapid growth, presence of pain. If the nodule is hard, irregular, limited mobility, nodule with hoarseness of voice, presence of local invasion or lymphatic or blood-borne metastasis. These are important factors you have to assess by history and by examination. What is the differential diagnosis of solitary thyroid nodule? In 50% of cases, it is part of multinodular goiter. So we call it apparently solitary thyroid nodule. In fact, it is not a solitary, but other nodules are impalpable. Second differential diagnosis is toxic nodule and colloid nodule, adenoma, carcinoma, cyst, And we have mentioned that the percentage of carcinoma is about 8 to 10%. What are the indications for surgery in solitary thyroid node? First of all, malignant cytology. Second, suspicious cytology. Sometimes when you do fine needle aspiration cytology, the cytologist cannot inform you whether it is malignant or benign, but he advises you for excision. So, suspicious cytology. Large size, especially more than 5 centimeters in diameter. Pressure effect and substernal extension. Clinical suspicion of malignancy. And we said when you have to suspect clinically the possibility of malignancy in solitary thyroid nodule. Cosmesis for cosmetic purposes. Male sex. Rarely male patient can spare surgery. Male patient with solitary thyroid nodule can spare the surgery. Rarely. Most of the patient with solitary thyroid nodule should have surgery because high risk of malignancy. As I said, when it is solid, it reaches about half of the cases are malignant. Another indication, cysts recur after aspiration. What are the required investigations in solitary thyroid? First, blood investigations, thyroid function test, T3, T4, and TSH to assess the thyroid status. As I told you, that toxic nodule, very, very rare to be malignant. Malignant thyroid nodule usually are non-functioning. Also, we have to send the patient for thyroid autoantibody because it may be part of Hashimoto's thyroiditis. For serum thyroglobulin as a tumor marker. And for 24-hour collection of urine for catecholamine. You remember men type 2 syndrome because it may be medullary carcinoma. So we have to exclude the possibility of pheochromocytoma. Ultrasonography, the investigation of choice in solitary thyroid nodule. Feature suggestive of malignancy in ultrasound. Sonolucent cyst with echogenic internal wall projection. That means there is a cyst and there is internal growth inside it. Rich in vascularity. Rich in microcalcification. Can detect jugular lymphadenopathy by ultrasound. Also, ultrasound guided fine needle aspiration cytology of gland and lymph node can be done. Because sometimes when you do fine needle aspiration cytology, the nodule inside the thyroid gland, either it is too small to be targeted by the fine needle, and you aspirate from a site away from the fine needle, from the solitary nodule. Also, the importance of ultrasound and the suggestive feature of malignancy in ultrasound, cyst larger than 3 to 4 centimeters. 14% there is chances of malignancy. Ultrasonography replaced radionuclide scan in solitary thyroid nodule. Also, one of the very important investigation is fine needle aspiration cytology and isotope scan, which was previously very important investigation. Now not routinely done. Nowadays, not routinely done. Most commonly used isotope is technetium-99. It can demonstrate 3 different patterns as follows: either hot nodule or warm nodule or cold nodule. Cold nodule, it is the nodule that not take the isotope. Warm nodule, it is the nodule that take the radioisotope like the normal thyroid tissue. Hot nodule take excessive radioisotope technetium more than adjacent normal thyroid tissue. Hot nodule very rarely to be malignant. The high possibility of malignancy is in cold nodule. Not all cold nodules are malignant, and not some of the warm nodules are malignant. The differential diagnosis of cold nodule could be due to hemorrhage, hematoma, carcinoma, thyroiditis, and thyroid cyst. What is the treatment of solitary thyroid nodule? This depends on the clinical findings, sonography finding, fine needle aspiration cytology result. So, according to fine needle aspiration cytology result, for example, if fine needle aspiration cytology reveals it is papillary carcinoma, we should do total thyroidectomy with central neck lymph node dissection. If it reveals medullary carcinoma, we should do total thyroidectomy with modified radical lymph node dissection. If it reveals adenoma, we should do lobectomy with hemithyroidectomy. If it reveals toxic nodule in young patient, we should do lobectomy. And toxic nodule in elderly, we should do lobectomy or radioactive iodine 131 ablation. If it reveals colloid nodule, we should observe and give thyroxine 0.1 to 0.2 milligram per day. If it reveals simple cyst, we should do aspiration. If it resolves, we should wait and watch. If recur, lobectomy. Thank you very much for your listening.